Autoimmune hemolytic anemia is an autoimmune disease. Look at this picture, shows that disease mechanism and pathophysiology. Detail going on. Introduction. Autoimmune hemolytic anemia AIHA is a rare condition in which the immune system mistakenly attacks and destroys red blood cells, leading to hemolysis and anemia. It can be a primary disorder or secondary to other conditions such as autoimmune diseases, infections, or malignancies. Early diagnosis and appropriate management are crucial to prevent severe complications. Definition: autoimmune hemolytic anemia is a disorder characterized by the premature destruction of red blood cells due to autoantibodies that targets and destroy erythrocytes, leading to anemia and related to complications. Etymology: the term autoimmune hemolytic anemia comes from three key components. Autoimmune derived from Greek autos, a self, and Latin immunis, expand, protected, referring to the immune system mistakenly attacking the body own cells. Hemolytic: from Greek hema means blood and lysis destruction, indicating the breakdown of red blood cells, and anemia from Greek without and hema blood, meaning deficiency of red blood cells or hemoglobin. Together, the term describes a condition in which the immune system destroys its own red blood cells, leading to reduced oxygen carrying capacity in the blood. Types: 1. Warm autoimmune hemolytic anemia caused by IgM autoantibodies that react optimally at body temperature 37 degrees Celsius. 2. Gold agglutinin disease caused by IgM autoantibodies that react best at cold temperature below 30 degrees Celsius. leading to red cell agglutination. 3. Mixed type AIHA, a combination of both warm and cold antibody mediated hemolysis. 4. Drug induced AIHA resulting from drug interactions that stimulate autoantibody production or alter red cell antigenicity. 5. Proximal cold hemoglobinuria PCH, a rare type associated with IgG autoantibodies that cause hemolysis upon warming. Causes: 1. Primary idiopathic AIHA. 2. Secondary AIHA due to autoimmune diseases such as rheumatoid arthritis, infections, example mycoplasma, pneumonia, lymphoproliferative disorders, example leukemia, lymphoma, drug induced, example penicillin. Risk factors: 1. History of autoimmune diseases. 2. Viral or bacterial infections. 3. Blood transfusion. 4. Lymphoproliferative disorders. 5. Use of certain medications. 6. Genetic predisposition. Complications: 1. Severe anemia leading to fatigue and organ hypoxia. 2. Hemolytic crisis requiring urgent medical intervention. 3. Splenomegaly, enlarged spleen. 4. Increased risk of thromboembolism. 5. Cardiac complications due to severe anemia. Pathophysiology: the immune system produces autoantibodies that bind to red blood cells. The autoantibody coated RBCs are destroyed by the complement system or by macrophages in the spleen and liver. Hemolysis leads to anemia, jaundice, increased level of bilirubin. The bone marrow compensates by increasing erythropoiesis but may be overwhelmed in severe cases. Pathophysiology of autoimmune hemolytic anemia step by step process. 1. Immune system dysfunction. The body's immune system mistakenly identifies its own red blood cells as foreign. Autoantibodies IgG or IgM are produced against RBC surface antigens. 2. Antibody binding to RBC. In warm AIHA IgG antibodies bind to RBCs at normal body temperature 37 degrees Celsius. In cold AIHA IgM antibodies bind to RBCs at colder temperature less than 30 degrees Celsius, usually in peripheral circulation. 3. Complement system activation, especially in cold AIHA IgM antibodies activate the complement system, leading to absonization. Complement proteins, example C3b, attack to RBC, making them targets for phagocytosis. 4. Destruction of RBC. Hemolysis. Extravascular hemolysis, mostly in warm AIHA. IgG coated RBCs are recognized by macrophages in the spleen and liver. Macrophages engulf and destroy RBCs, reducing their lifespan. Intravascular hemolysis, mostly in cold AIHA. Complement activation leads to direct RBC lysis within blood vessels. 5. Hemoglobin release. Consequences. RBC destruction releases hemoglobin, which is metabolized into bilirubin increased unconjunctivated bilirubin leads to jaundice. Free hemoglobin binds the heptoglobin, reducing its levels. Hemoglobinuria. Hemoglobin in urine may occur in severe cases. 6. Bone marrow compensation. The bone marrow attempt to increase RBC production. Reticulocytosis increased immature RBC occurs but may not fully compensate for RBC loss. Seven clinical manifestations: fatigue, pallor due to anemia, jaundice from bilirubin buildup, splenomegaly, enlarged spleen due to RBC destruction, dark urine from hemoglobinuria in severe cases. This cascade results in anemia, increased bilirubin levels, and compensatory bone marrow response, which are the hallmark features of AIHA. Signs and symptoms: 1. Fatigue and weakness. 2. Pallor or pale skin. 3. Jaundice, yellowing of skin and eyes. 4. Dark colored urine. Hemoglobinuria. 5. Splenomegaly and hepatomegaly. 6. Shortness of breath and tachycardia. 7. Cold induced symptoms in CAD. A diagnosis: 1. Complete blood count CBC shows anemia with reticulocytosis. 2. Peripheral blood smear reveals spherocytes or agglutination. 3. Direct antiglobulin test confirms presence of autoantibodies on RBC. 4. Serum bilirubin and lactate dehydrogenase elevate in hemolysis. 5. Hepatoglobin levels decreased due to hemolysis. 6. Cold agglutination titer and Donat Lendersena test specified for CAD and PCH respectively. Nursing diagnosis: 1. Fatigue related to decreased oxygen carrying capacity of blood. 2. Risk of infection related to immunosuppressive therapy. 3. Impaired tissue perfusion related to hemolytic anemia. 4. Altered comfort related to pain and malaise. 5. Anxiety related to chronic illness and uncertainty. Medical management. 1. Corticosteroids, example prednisone. First line treatment for warm AIHA. 2. Immunosuppressants, example rituximab, azathioprine, cyclophosphamide, used in refractory cases. 3. Plasma psoriasis helps remove autoantibodies in severe cases. 4. Intravenous immunoglobulin used in severe hemolysis. 5. Splenectomy considered if steroid therapy fails. 6. Blood transfusion used cuteously due to risk of alloimmunization. Nursing management. 1. Monitor vital signs and symptoms of anemia. 2. Assess for jaundice, pallor and signs of hemolysis. 3. Provide oxygen therapy if necessary. 4. Educate patients on avoiding cold exposure in CAD. 5. Administer medications as prescribed and monitor for side effects. 6. Provide emotional support and counseling. Treatment options. 1. Pharmacological treatment, corticosteroids, immunosuppressants, rituximab, IVIG. 2. Surgical treatment, splenectomy for refractory cases. 3. Supportive care, blood transfusion, folic acid supplementation. 4. Lifestyle modifications. Avoid triggers, cold exposure, infections, and certain drugs. Psychosocial medicine. 1. Counseling and emotional support help patients cope with chronic illness. 2. Patient education, inform about disease, triggers, and medication adherence. 3. Support groups, connect with others experiencing similar conditions. 4. Stress management, techniques like medication, relaxation, exercises. 5. Financial and social support, guidance on managing healthcare cost and lifestyle. adjustment, prevention. One, avoid known triggers such as certain drugs or cold exposure. Two, manage underlying conditions that may contribute to AIHA. Three, regular monitoring for early signs of hemolysis. Four, maintain a healthy immune system through vaccinations and good hygiene. In conclusion, autoimmune hemolytic anemia is a complex disorder requiring a multidisciplinary approach for effective management. Early diagnosis, appropriate treatment, and ongoing monitoring are essential to prevent complications. With proper medical and nursing interventions, patients can maintain a good quality of life while managing their condition. Thank you. Have a nice day.